very proud to be here today. My name is Nina Davis, and I'm chairman of the Ethics Committee of the International Continence Society. And we have a very special program for you today that is actually a first for the Ethics Committee to sponsor. And we're sponsoring it through just ideas, not through money. I just want to make that clear. Somebody said sponsoring was a funny word. But I have the great pleasure and honor to introduce somebody who doesn't need much of an introduction to the people of the ICS. He's Dr. Rosier, our urodynamics guru, and I want to remind all of you that guru means teacher, guide, and master, and he is going to guide you through an excellent program today dealing with the ethics of performing urodynamic examinations before surgery for female stress urinary incontinence. So without further ado, I will turn the podium over to Dr. Rosier, who will then introduce our other speakers. Thank you.
Thank you very much, Dr. Davis. Yes, I might be a guru, and so that you conclude that I'm heavily biased in this perspective. And yes, but I accept that there is discussion and that discretion is there, both in the scientific and in the clinical practice. So before I invite my two colleagues, lecturers on the podium, this is where we all began with. Primum non nocere is first do no harm, and I think that is the most important ethical rule that we have in healthcare. And in practice, this means, especially for the topic of today, that you should not do too much diagnosis, not too little, and you should manage not too much and not too little. So please, Xavier and Victor, come to the podium. While they are here on the way, I introduce Professor Victor Nitti, and you can see that he has a very important position in New York and a very important position in the Urological Association. I introduce Professor Fritel, Xavier, I will say, and he is a professor of gynecology in France, in Poitiers. So, here are our business cards. We do research, but I don't think that has much influence on our talk, and if yes, just tell us. Here was the question: is it ethical to perform urodynamic investigations prior to surgery for female stress incontinence? And what we have prepared for you is that I'm going to ask a question, and both Xavier and Victor will answer that. And again, a question. And the first questions are the technical ones. What's the evidence? And then the third question will be the ethical one. What do we do on the basis of the evidence, and on what do we consider good ethical practice? So, there are the three questions. Who is your ideal patient for surgery, and who is not? And then, what do you do to select the best one and the best one to do not? So, here's the real question, and I will ask Professor Fritel to answer the question first. Which patient is your optimal candidate for standard surgery for urinary stress incontinence? What do you consider to be the evidence for that? And what is the prevalence of optimal candidates in your practice? Professor Fritel.
Thank you, Peter. So, from my point of view, and I will present the evidence available, what I know from the evidence. The best candidate for me is a woman with uncomplicated stress urinary incontinence. We may debate with what is exactly uncomplicated stress urinary incontinence. So, with a predominant stress symptom, and we know there is some level of evidence to show better result if stress urinary incontinence are predominant. With no nocturia, I am afraid I have no proof of that, but it's clearly, for me, a clinical evidence, and with Nocturia, you may wondering what's happened, and cannot be related with stress urinary incontinence. With a normal uroflowmetry, a non-invasive uroflowmetry, because I tried to do non-invasive investigation for stress urinary incontinence, but I don't know exactly if there is proof, because the 2 RCT Victor is going to speak about include only a woman with normal uroflowmetry, a normal bladder capacity, but again, I have no proof to have advance. A significant urethral mobility, we are going to see that in another slide. A positive cost test and no previous surgery, but I am afraid, again, I have no proof to advance now. Yeah, yes. We know that we have show and demonstrate that with for the surgery with mid-urethral sling, you may have a better surgical result, a better objective success rate when there is a significant preoperative urethral mobility. Again, with a low urethral mobility, the result are decreased with more failure. And when you take into account the urethral mobility preoperatively, the intrinsic sphincter deficiency doesn't change the result if there is some significant mobility. I don't know what is the best way to assess urethral mobility. In this work, we use lateral cystourethropy. Now, in my practice, I use clinical assessment or ultrasound, but I don't know what is the best. You know, when there is some urge symptom with stress symptom, you have a lower stress urinary cure rate. One of the hypotheses to explain that it's maybe when there is urge symptom associated with stress symptom, it's because the urinary incontinence is more severe. This paper have some argument in this direction. In our institution, Poitiers, it's a small town in France, around half of the patients in the urology department may consider as uncomplicated stress urinary incontinence, and 3/4 in our GYNOPS department. All patients are assessed in the same way in the 2 departments with standardized questionnaire, non-invasive uroflowmetry, frequency volume chart, and urine analysis. It's a mistake with urine cytology, urine analysis.
Thank you, Xavier. Professor Nitti, Victor, you can answer the same question.
Well, when this question was posed to me, I thought about it a little bit differently. And I agree 100% with what Xavier just said regarding sort of the optimal profile and the patient that you think going into it has sort of the best chance for a successful surgery based on the parameters. And the right side of my slide is pretty much a mirror image of what his slide was. But when I really thought about it and I said, well, who's the patient that I most want to operate on, I think of the patient that's highly bothered by her condition. She's definitely interested in having surgery. She's fit for surgery, understands the risks, has reasonable expectations. This to me is so important, that the patient is able to understand what I am telling her are the reasonable expectations from the surgery, and understands the limitations of the surgery, so that if it is a patient with mixed incontinence and we do decide to treat her stress incontinence with surgery, that she understands that, well, her urgency symptoms might get better. They'll likely stay the same, well, depending on how bad those symptoms are. But they might get better, they might stay the same, or they could get worse. And I think it's important that she understands why the operation is being done, and that if she's mostly bothered by urge symptoms, that we've exhausted all of the things for all of the treatments for those urge symptoms before we move on to treating her stress incontinence. I don't have any level of evidence for this. This is just my level of confidence as I see a patient. Now, I would say that one thing we've clearly noticed at New York University, and we have some pretty striking data to support this, is that when we looked at the number of patients that we see, and this is myself and my senior most partner, so we've been in practice together and had the same practice patterns for the last probably 15 years. She's been with me, I think, for 12. And we advise the patients the same way. And what we've seen in the last five plus years, and this correlates with the FDA notification, is that the number of new patients that we see presenting with stress incontinence has increased. And the number of surgeries that we do, despite advising patients exactly the same way, has decreased fairly significantly. So for some reason, less patients are opting for surgical treatment in our healthcare system. I would very much agree with the concept that if we think about that ideal profile, what we see in our practice is probably about 40 to 50% having that profile, and probably about 50 to 60% being a little bit more complicated, and that's probably because of where we are and the setting that we're in, et cetera. But we do see a fair number of what I would claim to be uncomplicated patients. Now, as you start to think of the concept of who needs or who benefits urodynamics, we can look at two studies, one from the US, the value trial, one from Europe, from the Netherlands, and they were done a little bit differently, but they came up with similar conclusions. Now, these are patients who are what we would call the optimal candidates. They're good candidates for surgery. They have demonstrable stress incontinence. They don't have a lot of urgency symptoms. They empty their bladders normally. And in the value trial, it was a non-inferiority trial, and the patients were randomized to office evaluation alone, which are basically the things we just spoke about, versus office evaluation plus urodynamics. And at a year, there wasn't any difference in surgical outcomes. The study in the Netherlands was done a little bit differently, but when urodynamics were done in everybody, but when the urodynamic finding wasn't straightforward stress incontinence, even though the patient came with that complaint and appeared to be a sort of an optimal candidate for uncomplicated incontinence, when they had discordant findings, so they had detrusor overactivity, well, the detrusor overactivity was treated, or they had some emptying issues on urodynamics, so that was treated. At the end of the day, 92% of them ended up having surgery anyway, versus 95% of the patients who had what we might consider to be normal urodynamics, except for the demonstration of urodynamic stress incontinence. So an immediate mid-urethral sling wasn't inferior to individualizing treatment and then going on to a sling. But again, those are very select patients. They looked at the value trial data, and they found that when patients had urodynamics, it gave the physicians greater confidence in their clinical diagnosis, but it didn't correlate with treatment success. So the doctor felt better, but the patient didn't necessarily benefit anymore from that. Now, there are a couple of studies that could support the use of urodynamics in what we might consider to be uncomplicated stress incontinence. But I want to emphasize that this would mean that your choice of operation would be affected by the urodynamics. And essentially, this would assume that, at least for me, that your primary operation would be a transobturator sling. Now, I'll be honest with you and tell you that that is not my primary operation. I prefer to do a retropubic sling almost always over a transobturator. That's my bias for other reasons and is not the topic of this debate. But what I will say is that for me, this doesn't apply, because these things are not going to change my decision for the most part, although it might change your decision or it might change someone else's decision. So there are a couple of studies that have shown if patients have low leak point pressures or low maximal urethral closure pressures, they do less well with a transobturator versus a retropubic sling. Now, I will say I could criticize those studies by saying they didn't take into account urethral mobility, and if they did, maybe that would wash out. But that's the data that's there. So if you believe that data and you would, for whatever reason, prefer to do a transobturator sling in the index patient, but you would change your mind based on a leak point pressure, then you can argue it's affecting my decision. It's very reasonable to do a urodynamics test. So I looked at, if it's not ethical, that means it's unethical. And unethical means, I guess in the US, it means not conforming to a high moral standard or morally unacceptable. And in the UK, it would be not morally correct. So if you do urodynamics, does it fit into either of these categories? I think if you look at the guidelines that various societies have put forth, they give a lot of freedom and give a lot of discretion to the person who would perform the urodynamic. So if you look at the AUA-SUFU guideline, clinicians may perform multi-channel urodynamics in patients with symptoms and physical findings of stress and con. Doesn't say you have to do it, doesn't say you shouldn't do it. And I think you can make arguments even in the uncomplicated patient if it's going to affect your decision where you might. The EAU guidelines are actually quite similar to that, same general idea. The ICI is a little bit stronger, and Peter was the author of this, in their recommendation that urodynamics should be carried out in all women prior to surgical intervention. And as this gets updated next year, perhaps that recommendation will change. We'll see. Was that the end, or am I still up? Okay, so when is it ethical to perform urodynamics in a woman with uncomplicated stress incontinence? In my opinion, when the outcome of the urodynamics will affect the type of surgery performed. So I would say for me standing here, if it's not going to change my operation, I wouldn't do the urodynamics. If I thought the outcome would affect patient counseling for whatever reason, then I think it would be reasonable to do it. And this is going to vary depending upon the surgeon and depending on what that surgeon's particular choices are in how they treat the condition. And I'm not saying one way is better to treat the condition than the other. Thanks.
So the good message is that there is evidence, but the sad message is that the evidence is not providing all solutions, and that's why the guidelines are so vague in my perspective. Okay, you missed the beginning slides, and here's the red devil, and that's the patient that you would not operate on. And in the beginning we talked about the white angel. Vic, again, can you explain who you would not operate and what you do for diagnosis?
Or what I would say is somebody that I feel would really benefit in my hands from further evaluation. And I think if they do have significant overactive bladder symptoms or overactive bladder dry symptoms, frequency volume chart, and then possibly urodynamics in that patient depending upon the findings on the frequency volume chart. That's a little bit of a soft call, and that's one that there's going to be some clinical judgment that comes in. I think if they have significant urgency incontinence, that's somebody I want to understand a little bit more about their bladder and about their urgency incontinence. And perhaps, although there's not a great level of evidence, the type and the frequency of detrusor overactivity might affect my decision. I think it would, although I can't say that there's a huge amount of evidence to support that. Voiding symptoms. So if a patient has voiding symptoms, if I do a uroflow test and it is abnormal, that would oftentimes prompt the urodynamic investigation. If they have a significantly elevated post-void residual and it's repeated and it's still elevated, that's somebody I would do urodynamics on. If they failed prior surgery, now this is one, I have to say, most of us still subscribe to this, but I will tell you that this could change, because if they failed prior surgery, but other than their failed prior surgery, they would otherwise be quote unquote uncomplicated, Maybe that patient doesn't need urodynamics every time, but we don't know that yet. So that's still a patient that I would opt to do urodynamics on. If there's been pelvic irradiation, for sure. I always that always raises a level of suspicion for me. Significant neurological disease, that's sort of a no-brainer. In the history of pelvic irradiation, you might even make an argument that if it's severe enough radiation, you would opt away from a mid-urethral sling. If it's a totally fixed urethra, and I will say in my experience, these patients are rarely uncomplicated. Elderly women, I don't think the studies that have been done on uncomplicated stress incontinence have enough of elderly patients in it to make me feel comfortable that they don't need further evaluation. So if I have a woman in her mid to late 70s or 80s that I'm considering operating on, I still feel that the level of evidence that's available does not include enough of those patients to give me that comfort level. Very severe stress incontinence. I think that, and I'm talking about the patient who's in diapers for the most part. Again, I don't think these patients are sufficiently represented in the clinical trials that tell us that we don't necessarily need to do urodynamics. So these are patients where I think that the level of evidence isn't quite there for me to classify them as uncomplicated.
So, Xavier, it's your turn again.
So it's difficult to add something after Victor. So as we have seen, we need to investigate in case of urge symptom. I have highlighted the case of Nocturia, of course. I will be concerned by pain and pelvic pain, of course. Hematuria, it's why I think you need urine analysis, recurrent infection too, voiding symptom, and especially leakage just after voiding. And of course, fail initial surgical treatment. And we do frequency volume chart for systematically, uroflowmetry, but we may add cystoscopy in case, of course, of pain or hematuria, of course. We may add, and it's mistake, it's missing the ultrasonography to assess. I use it when I am not so sure of the mobility of the urethra. It's not so easy. In most cases, you can have it clearly clinically, but in some cases you may need ultrasound, and it's easy to perform perineum ultrasound in my GenOps department, of course. And I will use urodynamics, of course, in case of urge symptom. I am not sure. I am not going to operate. But I will ask for more investigation. So most of you use urodynamics to define intrinsic sphincter deficiency. You may have some clinical symptom or sign of intrinsic sphincter deficiency. We know that the empty stress test is a good marker for low maximal urethral pressure or low Valsalva leak point pressure. The fact that you may observe leakage without any mobility, it's a marker of intrinsic sphincter deficiency. And the fact of observing some leakage when you support the bladder neck or the urethra, it's a Bonnet maneuver. It's in favor of intrinsic sphincter deficiency too.
Good for the Red Devils. Still 20 to 30% fails after initial surgical treatment. And the study that shows what the diagnosis has been and what effort has been done to make a diagnosis is still lacking for that subgroup. Nobody knows what preceded the failures. So there's the ethical part. And this is an ethical, let's say, definitions. Maximalization or optimizing, satisfying. You do things until you are very certain, and in this case, in stress incontinence, you might balance invasiveness of diagnosis versus the risk, and the risk of diagnosis versus the risk of treatment. And that is a balance. And overall, there's the tendency for regret minimization. And the regret minimization nicely alliterates, I should say, with the do no harm. We do not want to cause regret, not for ourselves, not for our patients. So my question to both Xavier and Victor is, how do you handle, how would you describe that you apply these principles in your practice? And is it ethical to do or to do not urodynamics? So there you go, Victor.
Okay. Well, I think there's and I am in support that it's ethical to do urodynamics, or it's certainly ethical to do urodynamics under certain situations. But, you know, it just struck me, as Peter was saying what he just said in regret minimization. I will tell you that I have seen instances where the urodynamics have actually, in my opinion, led the surgeon to do the wrong thing, because the surgeon relied too much on the urodynamics and not enough on the clinical scenario. And I see that, it's a little bit off the picture here, but I see that more in men with post-prostatectomy incontinence, where I think you can be very misled by urodynamics sometimes with respect to voiding parameters and overactivity, et cetera. So it comes with, you know, we always make the assumption that urodynamics is the end-all and be-all, but sometimes the urodynamics can be wrong and the clinical picture can be right. Where the challenge for us is to figure out when that is. But I perform urodynamics. I think it's totally justified for me to do it if the diagnosis isn't obvious to me. So one thing I failed to mention before is if I have a patient who says they have stress incontinence and they give a pretty good history for it, but I can't demonstrate it based on simple maneuvers. I do worry about that, and I don't want to operate on somebody who doesn't have the condition. If surgery can potentially place the patient at significant risk if there's an undiagnosed condition. So you can imagine if somebody has neurological disease or has pelvic irradiation and they could have impaired bladder compliance, well, we can actually harm that patient by increasing their outlet resistance if we don't then do something to lower their storage pressures. So that's something where I think you know, if I'm placing a patient at risk other than the sort of normal risk of surgery. If the type of surgery is going to be affected, so as I said, if I was going to change what I do based on it, I think it's absolutely ethical that if I'm going to make a decision of type of surgery based on urodynamics, completely ethical. And then if counseling will be affected, and this is usually not for me, it's not going to be in the most uncomplicated patients. But I will tell you, if another physician in their heart of hearts truly believes that their counseling or their surgery is going to be affected by what they find, and in their practice they are comfortable and honest with themselves and their patients, I think it would be ethical to perform urodynamics, considering, again, the costs and risks of urodynamics. It becomes I mean, at the end of the day, we still are physicians, and I still believe there's enough of an art to medicine that that every single thing that we do cannot be answered in a randomized controlled study. We're still doctors, and there's something to be said for that. That's not to say we should ignore evidence. We should use it, but we should use it smartly and wisely.
We know that we face two limited options for primary stress urinary incontinence treatment. You may do nothing, pelvic floor muscle training, use a pessary, or operate her. So you need to take time. What is ethical is to take time to consider the indication for surgery. But I believe we can, in most cases, use non-invasive investigation to assess and to decide for surgery. The best predictive value for cure after mid-urethral wasting is the urethral mobility that you can assess clinically or by ultrasound. And you know now there is a very limited effect of urodynamic on decision making. especially for uncomplicated stress urinary incontinence. But as Victor said, for the other case, for complicated or for the associated with problems, just we still don't know. But perhaps in the future, it will be a debate about urodynamics and complicated stress urinary incontinence. I believe there is, of course, still selected indication for urodynamics. And for example, for unclassified incontinence, when I don't understand what's happened, when I can objectively observe the leakage, of course, we need urodynamics to see more what's happened. For my practice, of course, previous surgical failure is an indication. For the moment, I really need flow chart, I really need uroflowmetry, I really need questionnaire in this case. Urodynamics is not going to replace the clinical investigation, of course. I believe that we still need some evidence to improve which patient need surgery. And there is much work to do further. Thank you.
Okay, thank you both. There's a chance for a last word for you both, Victor. And we just had a small chat, and there will be a chance, I think, if time allows, to ask a question, but I do not know for sure whether time is going to allow us. But yes, I feel that we have heard the two gurus of clinical management. And I'm asking Victor, so how do you feel in between the angel patient and the devil patient? And can you give the audience some clue of a summary of how you handle the lack of evidence and the evidence that is there, and together with the ethics of too much and or too little diagnosis?
Well, you know, I didn't actually realize that's what you meant by that slide, the one in
Yeah,
between.
that was the
Now I
surprise.
know. Fortunately, I think I can come up with an answer for that. You know, I think that for that patient in between, I will still err on the side of more information versus less information in most cases. You know, another thing that I just thought of, and again, it comes down to me, how useful is it going to be? And for the patient in between, I would say today in 2015, I'm more likely to get additional information than I am not to get additional information. As that gets sorted out by my own experiences, or as perhaps treatments change, or as more data becomes available, I am open to change on that. I mean, I used to do urodynamics on every single patient before I operated on them, and I don't do that anymore, but I still do them on a good number of patients. Another thing crossed my mind as I was just standing, and I think we have plenty of extra time, I think it's good to mention this, is that in this room, we have a lot of people that are really interested in urodynamics and that do good urodynamics. But in certain parts of the world and in certain parts of my country, people don't necessarily do good urodynamics. And as I was thinking about what I said before about sometimes they can hinder your diagnosis, urodynamics done poorly may be worse than no urodynamics at all, because if they give you the wrong diagnosis, then you're going to go down the path of doing the wrong thing. So I think that's also important for a room like this where it's filled with people that, you know, do urodynamics, understand it, love it, use it to the best that it can be used, and put everything together with the clinical picture. More times than not, if I'm unsure, I like to have that additional information. But again, you have to realize that when we make broad recommendations and it goes out, in my case, all over the country or all over the world, there are people that will misuse sometimes that information, and we have to be careful about it. We're all experts here, but people that take care of stress incontinence around the world are not always all experts. So it's just another little caveat to put in there. But I'd say for the patient in the middle, more information versus less information. That's the short answer to my long-winded response.
So there you are, Xavier, in the same position.
Fine.
And also the question, can you prevent too much or too little diagnosis in every group?
I think in this situation, I just need time. And as Victor said, to consider what is going to help me, what sort of investigation is going to help me to decide and to help the patient. But I would consider urodynamic, of course, but another clinical examination with a filled bladder, of course. If the flow chart, the frequency chart is missing, to have it, and I will take another visit, another time with perhaps ultrasound, or maybe urodynamics. But again, I believe that urodynamics is not going to replace reflection and clinical assessment.
Thank you. I understand that we have time for a question. If somebody wants to ask a question, here are the guru clinicians for you.
Grzegorz Sulkan from Poland. I have a question, how you can approximately tell how big percentage is in uncomplicated cases in your practice? I mean, in how big percentage you do not do urodynamics before the operation?
So raise hands if you think that uncomplicated patients is a well-defined condition. Uncomplicated stress incontinence. There's 1 hand, 2 hands, 3 hands. So it's, I would say, a small minority that says that it's well-defined. What do you think? Is it a well-defined condition?
No, of course. No, of course, it's not well-defined. As Victor said, maybe it's a subjective definition for us surgeons. For me, in my practice, in most cases, I do not use urodynamic before stress urinary incontinence surgery, but I used to do a retropubic sling and not transambulatory sling. So whatever will be an intrinsic sphincter deficiency not going to change my position and my surgery.
I might force you, Victor, to say that it is a well-defined condition and ask you, what is the definition?
Okay, well, boy, it seems like I've now flipped to the other side of not doing urodynamics. But I think it's...
I might ask one of you that raised hand. What is the definition?
I believe that if somebody has symptoms that are exclusively or truly predominantly stress-related and doesn't have much in the way of overactive bladder symptoms by complaint or by frequency volume chart, they empty their bladder normally. You can go to the extent of doing a non-invasive flow if you want. Now, that's kind of urodynamics. So I don't know that that's necessary, but certainly if somebody has a normal flow, empties their bladder, is less than... Oh gosh, now I'm starting, but is relatively young, so I'll say less than 70. And hasn't had radiation and doesn't have neurological disease. I think that's a well-defined, uncomplicated group that I'm comfortable calling uncomplicated. So I think now, maybe 10 years from now, the definition of uncomplicated will be broader, or maybe it'll be more compact, but based on the data we have now, I think that's a fair definition. And I would say that those are patients that I would feel comfortable, demonstrable stress incontinence, not necessarily evaluating with urodynamics if I was going to do surgery, because I don't think it's going to change what I do.
So it might be a challenge for future ICI to consensus-based define that group. I see Professor Finazzo Agro, and I know that he published an excellent comment on an analysis of the studies, the American studies. So I'm happy to give you the microphone.
Yeah, thank you, Peter. I didn't raise my hand, but I think that if we want to use the data coming from the value trial, we should define the patients as uncomplicated using the same parameters you used in that study. So probably we should have in mind that list of inclusion and exclusion criteria and try to use that. I mean, it's a list, sorry, I cannot repeat, it's very long. But we should use that list to say that the patient is complicated or not, because this population was used to extract those data that now we are using to say that urodynamic in those particular patients may be omitted. So, I mean, I think that this is the definition to me. If I may add something, we have published very recently on neurology and neurodynamics a trial done retrospectively examining our series of urodynamics in Italy in several centers. And we have seen that patients responding to the criteria of uncomplicated were around 1/3 of our patients. So, I mean, I think that this is approximately the right number, because even if you look at data coming from the value trial, around 67 of patients were excluded because not having inclusion or having exclusion criteria. So around 33 of patients were considered for going into the trial. So 1/3 are uncomplicated to me, so from what I know from my experience and from literature.
So thank you. Adding on that a bit, now you are here, and there's your waiting room with 100 women with any kind of symptom of incontinence. Adding on to what Professor Finasiago said, if 1/3 is obvious, the easy ones, that are the angels, the obvious stress incontinence. 1/3 is the obvious not, and 1/3 is in the middle. Does that epidemiologically idea raise much hands for you? Am I very wrong in that? Am I very wrong? Is that we agree more or less in that estimation?
I think that's very reasonable, and perhaps those are the patients that we'll look at in the next decade or two and try and determine what the most useful testing is in those patients. And I think you can't discount an individual physician, an individual surgeon's experience and how they are going to approach a patient. You know, so often my fellows or my junior partners will say to me, why wouldn't you do urodynamics on this particular patient before treating them? And this isn't necessarily stress incontinence surgery. And one thing I always say, and it might not be precise, but you know, I've done thousands of urodynamics, and by doing so many of them, I've learned who I don't need it in before I make an initial step towards treatment. And I think that's just a degree of experience that you can't always put into a randomized trial that can be applied to every patient and every physician. I think there still is, I emphasize that there's still room for clinical judgment, and my clinical judgment may be a little bit different than yours, and neither of them may be wrong. They both may be wrong. But I think, you know, adding more information doesn't always change that. And I think we have to be smart about how we approach patients and not just say everybody gets everything, because I think then, you know, sometimes that's helpful and sometimes it's more confusing. So that middle third, I think those are patients we need to understand better. And my middle third may be a little different than your middle third, and they may be a little different than your middle third. And how much, or yours, how different really are they? And that's, you know, that's a little bit of the gray zone.
So, Xavier, teach us how you handle your middle third and maybe the bad ones without urodynamics. Is it possible to do that?
You know that I cannot, it's not easy to answer. I believe it's possible to take time to reset a clinical examination with an empty bladder, of course, to do an ultrasound assessment of the ureter. Just take some time. But I need to declare that I have done urodynamics by myself for 20 years. And it's perhaps that I have learned during these 20 years how to not use urodynamics. I have learned of this normal examination, that the main point that I have done during this examination is take time to reassess the clinical assessment of my patient.
So we do not disagree too much. How do you handle that 1/3 in the middle in your own practice? So the 1/3 is 100% now. Raise hands. If you do urodynamics in that middle intermediate diagnosis 1/3, who of you does urodynamics in all of those patients? So, who does urodynamics in the 60% that's not obvious stress urinary incontinence? So in all others, that's less, I would estimate, or not? Slightly less. And who would do urodynamics on every woman with whatever symptom of stress of urinary incontinence? So that's a minority. Okay, having said that, I could not else than conclude that I have learned a lot from you, and I've learned a lot of how to handle patients, and maybe which patients, without urodynamics. And the evidence is there, as it is, and we should incorporate that in our guidelines. And as was said, they are not clear enough yet. And I think we, in my view, we had the point that if we are able to define the straightforward stress incontinence, we might be able to do without urodynamics. But you seem to agree with me, most of you, that you still need urodynamics for a large proportion of patients. But there's a comment. Yeah, sure.
Although clinical evidence is not supporting, it's very low clinical evidence, because if we have to do or not urodynamic before. What about legal aspects that have left behind the topic? And what about decisions? Because in my hospital, in my country, I'm from Argentine, and asks me to perform a urodynamic before, because if we said we have a problem, we have a legal problem after the surgery. So what about informed consent and legal aspects?
Okay, thank you for that question. That's a little bit off topic, of course. If there is a law that doesn't allow you to do something without a certain test or not, you should do it, of course. But what is your opinion? Will that change in your country, or will that influence practice?
I don't think so. And you know, when I have a patient with uncomplicated stress incontinence that I feel very confident that they'll do well with an operation, assuming they want to be operated on, I do actually say to them, you know, I could do a urodynamics test of your bladder, which consists of X, Y, and Z. But in my experience, I don't think it's going to change what we're going to do. So I do tell them about it. Rarely do I have anybody that falls into that category that would say, well, why don't you just go ahead and do the test anyway? Now, if there's more uncertainty, or if it happens to be perhaps a patient who has prolapse and doesn't have stress incontinence, but you know, might choose to have an operation based on whether or not they have occult incontinence, and I can't figure it out on physical exam, and they can't hold the pessary in place. And I tell them, you know, this is the information we would get, and this is how I would advise you. They're more likely to opt to do it. But I think if your country requires it, you do what's required. And they'll spend extra money.
Would you go as far that you say that you ask a specific consent to not do urodynamics?
No.
No. Xavier, how is that in your country?
I was wondering, what are you expecting from urodynamics? If the patient completes your questionnaire assessing that she declare she reported stress urinary incontinence. As you have observed the leakage at stress on cough on Valsalva, as you have observed that the bladder, there is a normal bladder capacity using flow chart, as you observed that she was able to empty the bladder with uroflowmetry, what are you going to expect with urodynamics only for the lawyer? In case of failure, it's not, for my opinion, it's not going to change anything.
Okay, I think I finished this session. I thank you for being here. I thank you both.
I have a question for you.
You have a question? Excuse me.
I have a question for Victor. What is reasonable expectation before surgery?
So, you know, I mean, I think that the patient has to realize that there is a chance that our operation isn't going to work, that if it doesn't work, we might consider doing something beyond that. And I think more importantly, it's that if there's a constellation of symptoms, and I don't care whether they've had urodynamics or not, if there's a constellation of symptoms, here are the symptoms that I expect to be improved by my operation. Here are the symptoms that may or may not get better, and here are the symptoms that I really don't expect to get better. So, you know, if you're getting up 4 times a night because you drink 3 cups of coffee before you go to bed or have a bottle of wine before you go to bed, and you have stress incontinence, I might be able to cure the stress incontinence, but I'm not going to stop you from getting up in the middle of the night. And I think it's patients need, you know, some patients know it and some patients need to be told it. So I think that a patient that doesn't expect things from the surgery that the surgery can't deliver.
So you agree with me that it's a question of symptom and not of aerodynamics?
For the most part, I do agree with you. It's just if there's confounding variables, then that urodynamic information may be helpful or it may help you counsel the patient. But yes, I think that the symptom, and if you can demonstrate it on physical examination, those 2 things are the most important thing. Urodynamics, if you do it, should supplement that.
So I count to 10 and I try again to close this session. My thoughts for this session was to provoke thoughts and to provoke you thinking about what we are doing. And what we added is the discussion that I hoped would be there, and I hope that that you have enjoyed it as much as I did. And I'm a button member now, so that's more than 10 years. I'm not going to say how many years, but yes, it reminds me this kind of discussions at the old days of the ICS. I thank you for being here. Thank you for joining the discussion, and thank Xavier and Victor for being here and helping us so much with their clinical experience.
In the old days, it was nice to